So my talk was an invited lecture. It was during the educational session on ER positive, HER2 negative breast cancer. And my talk was actually looking into the benefit of giving post-menopausal patients endocrine treatment for the first 5 years after diagnosis, and then for the extended adjuvant endocrine treatment between year 5 and year 10. I have shown the milestone data that were developed since the late 90s, when early breast cancer, ER positive, was being treated with endocrine agents. It took 20 years to get the meta-analysis from Oxford to see a huge benefit in the breast cancer specific survival in lymph node negative patients of about 5%, in lymph node positive patients of about 10%. So this was a huge achievement. And then we had the trials comparing tamoxifen with aromatase inhibitors, also the first 5 years. And again, it took 20 years to see the meta-analysis that we did improve breast cancer specific survival. So if you give an AI for 5 years or an AI for 2 years followed by 3 years of tamoxifen, it's equal, and it improves your breast cancer specific survival with 2 to 3% as compared to 5 years of tamoxifen. Another option is 2 years of tamoxifen, 3 years of an AI, but that was a little bit less than 5 years of AI, but only during the 2 first years of differentials in treatment. Also important to mention is that the only predictive factor for a benefit of adjuvant endocrine treatment is the quantitative expression of the estrogen receptor. With the new definition of ER being positive by the ASCO-CAP guidelines, we have limited data for the patients with low ER expression, but we have an increasing benefit with an increasing number of the estrogen receptor. So we don't have today a lot of markers, molecular markers, to see who will benefit from treatment or who will benefit from escalated treatment using aromatase inhibitors. But the higher the risk, the higher is likely to be beneficial. Regarding the year 5 to year 10, there are a lot of trials in the extended setting with almost 25,000 patients in 12 different clinical trials, clearly showing a disease-free survival benefit of extending the treatment. But there the benefit is rather modest. And actually it comes on to the higher the risk based on the parameters that you have at diagnosis 5 years earlier, the more likely you benefit from this extended treatment. And the guidelines also say that if you have patients with more than 3 positive lymph nodes, you better go for the extended treatment. And if you have less than 4 positive lymph nodes, you have to look into clinical benefit as compared to potential side effects, because side effects give toxicity and sometimes the benefit is quite low, so you have to balance both against each other. And in the clinic we use CTS5, which is a score that gives us an estimate of the risk of metastatic relapse between year 5 and year 10. The last part of my educational lecture was on the SERDs, and the SERDs is an estrogen receptor degrader that's now going to be introduced in the adjuvant setting. So these are ongoing clinical trials, and we have to wait to see whether they are beneficial against the aromatase inhibitor or tamoxifen, or also whether they have less toxicity than these drugs. So to conclude, I have given an overview of the adjuvant endocrine treatment in postmenopausal patients as where we stand today.